Good evening. Good evening. Good evening, everyone. Vice Provost, ladies and gentlemen, guests and colleagues, you're all very welcome. On behalf of the Faculty of Health Sciences, it gives me great pleasure to introduce Professor Owen Smith, who will shortly present his inaugural lecture. There he is. Owen Smith, shy, retiring, easygoing, and aimless are not terms that people who know Owen use to describe him. Instead, you're most likely to hear Owen referred to as formidable, mover and shaker, indefatigable, a change maker, someone with unshakable belief and a strong vision. As a colleague put it, he may go right through you, but you know he has the best intentions for his patients at his heart. In 2022, Owen Smith was appointed Professor of Child, Adolescent, and Young Adult Cancer, having previously been Professor of Haematology in the School of Medicine at Trinity College. And that's why we're here today. He was Regius Professor of Physic from 2014 to 21, and is also visiting professor at University College Dublin. Even by the standards of our distinguished professors in the faculty, Owen Smith has had a remarkable career in academic medicine, not only for his clinical and research contributions, but also for his energy, his ability to articulate the public voice, and to influence decision makers. He is a demonstration of authentic authority and lived experience becoming a reference point for health policy. Professor Smith's accomplishments are outlined in the brochure, but believe me when I say that this is just a summary of an exhaustive list of achievements, leadership roles, and honors. Owen has somehow managed to navigate the labyrinth that is our health service and to emerge undaunted and ready to take on every challenge. Professor Smith entered Trinity College initially to read natural sciences and graduated with a moderatorship in biochemistry. The astute Keith Tipton saw Owen's interest in the clinical implications of blood disorders and encouraged him to study medicine, which he did in Trinity. Though, as he said, he had to work, and so did at the Meeting Place, a pub in Dorset Street on the north side, where he met the most amazing folk from the blues and traditional Irish music scene, and they've remained great friends ever since. Among them, Christy Moore, the Bothy Band, Clonard, Floating Dublin Blues Band, and The Business. And I think Dennis Doran, The Business, is here today. Great to see you. Graduation was followed by postgraduate training in adult and paediatric haematology at University College London Teaching Hospitals, where, as he said, he met the love of his life over the spleen of a patient at the Royal Free Hospital. Who knew that internal organs could be so romantic? A young Irish poet with a chronic myeloid leukemia over for a bone marrow transplant that was not available in Ireland at the time. He never looked back, and I'm not sure he looked back on the relationship or looked back on the haematology, but either way, he never looked back. At Great Ormond Street, Owen continued to impress, and Ian Hahn, who's with us this evening, Professor of Paediatric Haematology and Oncology, summarized his experience of Owen as, in a nutshell, he was the best trainee who worked with me during that 22 years. His publication output is exemplary, and in my field is known for his innovation and international reputation, with particular emphasis latterly in improving all aspects of management of the forgotten tribe of adolescent and young adult oncology. When he returned to Ireland, the management and arrangements for children with blood, bleeding, and malignant disorders was not at the best international standards. He virtually single-handed turned this around, and Ireland is now the envy of many countries in this respect. And I think that's such a high tribute to the man. Owen returned to Ireland as consultant haematologist at the National Children's and St. James's Hospitals and National Haemophilia Director. He's devoted the last 35 years of his career caring for neonates, children, and adolescents with cancer and blood disorders, encompassing basic science, clinical research, and patient care. He was appointed National Clinical Lead for child, adolescent, and young adult cancer at the National Cancer Control Programme, and he engineered the innovative All-Ireland Paediatric Academic Health Science Centre, of which he was the first chief academic officer. And this was a signal achievement to get CHI and 4 universities to commit to integration and cooperation. No better man. And I would very much also like to welcome the new CAO of CHI, Dr. Susa Bensler, who's just come in from Canada and is with us here this evening. Susa, you're very welcome also. In fact, Owen has become synonymous with the development of services for young people and a force for the realization of the new Children's Hospital at the St. James's campus. I can't imagine the persistence and drive it must have taken to constantly press the case for progress against all sorts of opposition and special interests. But if nothing else, Owen shows that hard work and the long game pays off. The government invited him to become a member of the National Cancer Strategy Steering Group with specific responsibility to advise on the needs of children, adolescents, and young adults. And as a result, adolescents and young adults have now been recognized for the first time in the Irish National Cancer Strategy as a distinct population within the oncology community because of their very different needs, and specific recommendations were made to address this health disparity. As if that wasn't enough, Professor Smith is the co-author of more than 400 research articles, letters, books, book chapters, abstracts, papers, signifying a significant contribution to clinical and basic science in pediatric and adolescent scholarship with international reach. But also, he has provided mentorship, education, and career development for the present generation of Irish pediatric haematologists. All of this has been supported by waves of grant funding from major national and international grant agencies. I could go on with the honors and accolades that Owen has received. He continues to lead a very long list of policy and strategy groups, champions many charities, including the Children's Medical Research Foundation, National Children's Research Centre, the Children's Leukemia Research Group, Barrettstown Hole in the Wall Gang Camp, and UK-based organisations such as the Children's Cancer and Leukemia Group and the Teenage Cancer Trust. Among his many national and international awards, in 2015, Owen was conferred Honorary Commander of the Order of the British Empire for his lifelong work on cancer in children and adolescents. Owen continues to live on the north side of Dublin, which he lists as one of his achievements, actually, with his wife, Jude, and his children, their children, Fiachra, Hannah, and Ewan. You're very welcome. Their 2 dogs, Benji and Bonnie, who are not here with us tonight. I'm surprised Owen has time to do anything else, but apparently he is known to relax by playing guitar. Though he's modest about it, I doubt that you do anything, Owen, without full attention and focus. We'd love to hear more on the guitar, but for now, Owen, I invite you to deliver your inaugural lecture, When Blood Breaks Down, Tales from Child and Adolescent Haematology and Beyond.
Wow, that's some introduction, and thank you very much, Brian, for that. And it's great to have the Vice Provost here texting on our mobile phone as we're about to. She's on Twitter already. So, Vice Provost, ladies and gentlemen, thanks very much for coming out on such a nasty evening to hear me for the next 45 minutes talk about tales. But as Brian said, this is my inaugural, and I'll cry and tell tales if I want to. And hopefully you'll see some of the tales are actually in the audience. It's not just my tale, but there are other tales that we will celebrate here this evening. So as Brian said, it all starts here in Dublin, in Trinity, in my senior officer year, final 4th year in biochemistry. And I met this guy here with the pipe, Professor Keith Tipton, who's Professor of Neurobiochemistry, a genius, a real problem solver. And he opened up my mind to a lot of things. And one of the projects in the final year was this particular problem to identify the specific defect in red cell pyruvate kinase enzyme responsible for the hemolysis in the child that was being looked after by Ian Temperley up in the National Children's Hospital at the time. This was a problem. Pyruvate kinase, it's a very rare disorder, but it does cause hemolysis. The patients are usually anemic and jaundiced and usually have a big spleen. And it was my sort of endeavor to try and find out why was this in this particular case. So it took me sort of several trips to Harper Street from the biochemistry department on the bicycle in the winter. And the amazing thing was I was going to pull blood, not me, but Bridie, who was the phlebotomist in Harper Street at the time, from a child who was already anemic. So that didn't fit right with me. But anyway, on 3 separate occasions, we pulled around 16 mils of blood each. Then I had to come back to the biochemistry department into the cold room for 14 hours. I did ammonium sulfate fractionation and then also some column chromatography. And after 14 hours in this cold room here, as you can see, I was listening to Pink Floyd, The Wall, that had just come out 2 months beforehand, and then onto the spectrophotometer, and then work out the problem that was causing hemolysis in this patient with known pyruvate kinase deficiency. And then fortunately, we published this in peer review in the International Journal of Haematology, showing the specific defect of this particular enzyme now is called pyruvate kinase Dublin. So with that in mind, then afterwards I switched over to medicine, and this is where Brian lives actually, and it doesn't look too dissimilar than 1926. So in medicine, then we went through the usual the preclinical years, and then in the clinical years, there was like most medical undergraduates are invited to go away and do an elective, usually in a low-income group or a third world group. And I chose West London to go to the Hammersmith Hospital to work with to work in the department that was organised by Sir John Dacey. He's the father of British haematology. He's actually responsible for the way we practice haematology in these islands, being sort of clinical as well as laboratory based. And within that department, there are household names here. You'll see John Goldman, haematology household names, John Goldman, Lucio Lassato, Galton, and Katowski, and these were fantastic hematologists, really shaping the whole area of hematology, adult hematology at the time. But I gravitated towards this guy here, Ted Gordon-Smith, and his 2 registrars, Jane Apperley, who's the head of the department now, and Judith Marsh, who's down at the London Hospital running their department for aplastic anemia. What I learned from these guys was how to actually procure marrow from the pelvis, but also how to infuse that marrow in the only departments of hematology in the UK at that time, transplanting patients for severe aplastic anemia. Came back then and qualified in medicine, did all my clinical work at Sir Patrick Dunn's under the tutelage of Professor Donald Weir, who's a real inspiration. And then this is us leaving Sir Patrick Dunn's after our intern year. We don't look too bad. We're still alive. That's me under the arrow. And this guy here, he looks like Benito Mussolini, but that's Tom O'Neill, who was a general surgeon. And I spent 3 months actually acting as a abdominal retractor for him for pulling back organs within the abdomen so he could do his surgery. The other surgeon I worked for was this guy here, a genius, David Lane, a brilliant surgeon and a brilliant musician. He was an oboe player, and he taught me how to make reeds for his oboe. I didn't think that was too bad a thing at the time. This guy here, F.S. Lyons, a neurologist, he introduced me to the humanities associated with medicine, in particular the history of medicine. And obviously here's Joe Kirker, a great neurologist, and his son, Stephen, was in my year as well. And everybody here will know Mary Henry, Senator Mary Henry. I used to do a varicose veins clinic with her. Had a great time there, but I was focused, as Brian was saying, and I knew I needed to get out of Ireland and go to train in haematology. And the nearest best place at that time I felt was the Royal Free Hospital because of these individuals here. Something new was happening in haematology. There was a lot coming into play in relation to the impact of chromosomal rearrangements in the leukemias, but also this whole area of immunotherapy that was coming. This is Malcolm Brenner here, a real international force in CAR T-cell therapies at the moment. And this is Dario Campana, George Gianossi, who's a Hungarian genius immunologist, who we started to look at monitoring of residual disease in leukemia patients. This is back in the 80s. This is real advanced stuff, but also Lorna Secker-Walker doing all the stuff on chromosomes as well in childhood leukemia. So I was an SHO, a registrar there, and then I became lecturer. And as part of that lecturing rotation, I was dispatched to Great Ormond Street Children's Hospital and the Institute of Child Health. And there I was exposed to childhood cancers, and more particularly to the whole concept of randomized prospective clinical trials, and also these weird and wonderful conditions called the inherited bone marrow failure syndromes. I was exposed to these three individuals here: Ian Ham, Judith Chessels, and John. John, he was a medical oncologist, but it was Ian that took me under his wing, and it's great to see him here. And he sort of really mentored me. And we started to write real significant publications around these rare disorders like Cosman's, like Pearson's, but also Schwachman-Diamond. You hear a bit more about that later on this evening. And we really were the first to show the true sort of natural history of Schwachman-Diamond in relation to the hematological issues pertaining to malignant transformation, and we'll see that later on. We also put in train to collaborate when I moved back here to produce two books, one for undergraduate, Essential Haematology and Paediatric Haematology, and they're still out there being sold. So I came back, as Brian was saying, in 1995, haemophilia director at the National Centre, both in Carpet Street and at St. James's, and then over the subsequent years, with the development of novel therapies, these new sort of factor concentrates, we went into partnership, I suppose, with some of the pharma companies, in particular Bayer, and we got funding. And it's great to see John O'Brien here, ex-CEO St. James's, and we started to build new facilities for the haemophilia population. This is the National Centre for Hereditary Coagulation Disorders. And also, again, research was important to me, so we developed a research program here in the Smurfit Cancer or Smurfit Genetics building in Trinity, and we started to look at stuff on endothelial biology, the meningococcal sepsis, and be published widely on that. In 1998, then we moved from Carpet Street with the Mead and the Adelaide into this building here out in Tala. And that was a great time, and there's a lot of people here who worked with me in Tala at that stage. And then, but eventually in 2002, we moved into Crumlin, the whole haematology, haemophilia, etc. Everything was going to be centralized into Crumlin. It's great to see Michael Lyons here. He was part of that program that pulled this all together, so we could concentrate for the first time in this country on cancer and blood disorders. And it was at that stage I made the decision that I would step back from being the National Haemophilia Director, and I handed that on to Barry White, who's here, and he took that on further. But I also handed over the directorship of the research program to Professor James O'Donnell, and this allowed me to concentrate far more on the problem at hand in terms of the hematological malignancies. And as you can see from this, ALL, the commonest cancer in the under 20s, was the prime sort of target for me in terms of getting most of these patients onto clinical trials. Now, my first sort of exposure to leukemia comes, anybody guess the date? What year? What's the year? It's not 64. When was Nelson's Pillar blown up? It was blown up on the 8th of March, 1966. But I thought that was a difficult one. I thought you would have got Des Fitzgerald should have got Revolver here. It was released on the 5th of August, 1966. So this was Temple Street, 1966. And this guy had come back from the States, Seamus Cahan, and he was a pathologist, and he had just introduced the whole thing, screening on PKU, polyketonuria, into neonatal screening in this country. He was also the pathologist at the time. And my cousin Derek came in. He lived down in North William Street Flats in Dublin, just across from where the Luftwaffe bombed North Strand. And he came in after about a 3-week history of just feeling out of sorts. And this reminds me to remind you to buy this book, Temple Street, An Illustrated History by Barry Kennick. And when I spoke to Barry about Derek, he pulled the microfiche and showed me the clinical notes back in 1966. So Derek was registered and admitted to, this is for Sinead Murphy, onto, what's that, St. Michael's Day. I think St. Michael's Day is still there in Temple Street. But we didn't have phlebotomists or junior doctors did not take blood. It was the lab assistants. And anyway, Seamus made the diagnosis of leukemia. His white cell count was very high. His platelets were low. He was bruising and he had a lot of problems with his chest. And the chest x-ray at the time showed whiteout. So that tells me that this is probably going to be a T-cell leukemia. And at that stage, and across the world really, these children were put into a quiet room, put on fluids, and given morphine. Not surprisingly then, on the Thursday of the 8th of December 1966, Derek passed away, as was the case with most children in this country and around the world. Now, in the 1960s, as you can see here, combination chemotherapy had been around for at least 20 to 30 years. These children were going into remission, but as you can see, we're losing control and there were no real long-term survivors. The real light bulb moment comes in the 1970s, 71 in particular, in the Blood paper published by the St. Jude group. This is Don Pinko, one of my other heroes, and who decided to try and address the CNS. Most of these patients were relapsing around their brains. So he went after their brains in the form of giving radiotherapy to their brain and also directed intrathecal chemotherapy. And as you can see, that curve is flat. So he was, in 1971, he was curing around 70% of these children. The Germans then stepped in, Berlin, Frankfurt, Munster group, and this is Rehm here from the Free University of Berlin. They decided to step up the ante here and give more intensive chemotherapy. And look, we're starting to see 60, 65% of these children are survivors. Around the same time then, we started to understand the risk, the classifications a little better about leukemia. All leukemias weren't the same, like you can see in all of these children. These are all different, and most leukemias are different. By age, if you're between 1 and 10, you tend to do really well. If you're below 1, you tend to do badly. And the further out into adolescence you go, the less well you do. We started to understand that T cells and B cells were different types of leukemia, T cells doing less well. And then the presence of chromosomal abnormalities within the leukemia cells were also predicting outcomes. So you see this one here, the ETP6 RUNX1 or the high hyperdiploids, they do rather well. The poor ones are these Mill, Philadelphia, or hypodiploidy, and the very poor ones, and we'll talk about that in a second, D2A HLF, they're almost incurable. And then the Germans started to look at response to treatment, 8 days of chemo or 8 days of steroid. You could predict who are the good actors and who are the bad actors. And then the real game changer happens with looking at measurable residual disease using biological assays in the laboratory. And the ones here that made the difference was looking at a polymerase chain reaction, looking at rearrangements on these leukemia cells of the B cell, of the T cell receptor, or the immunoglobulin chain. So we were well equipped then, coming into the late 90s, early noughties then, to actually re-look at how we were going to be treating these patients. When I came home, you can see here the UCAL Ian Han was responsible for some of these trials, and to give him his credit. And we jumped from 71 to 78% event-free survival in the early to mid-1990s. And that we were lagging behind, Britain and Ireland were lagging behind, say, continental Europe, and indeed the American group. And then this trial came out of the blue, basically. We decided to relook and recharge our whole effort. And this was purely for T-cell and B-cell ALL, with the exclusion of Burkitt leukemia or infant leukemia or the so-called Philadelphia leukemia. There were 45 centres across the UK involved in this particular trial, and one in Ireland because we collapsed the 4 units in Ireland, Cork, Galway, and 2 in Dublin into 1 into Crumlin. And this trial opens in 2003, and Lorna's story is here. She was with me when we opened this, and it was open to up to 18-year-olds initially. And then we started to creep into adolescents and young adults. As you can see, by June 2008, we had enrollment of all the up to 25-year-olds, the so-called adolescent young adult cohort. The amazing thing is we recruited over the life of this trial over 3,200. The amazing thing was that we had around 9% of the total cohort from Ireland in this particular randomized phase 3 trial. We were only second to Birmingham. And so that was a great achievement as well from this country in terms of this. And the question really we're asking, using these new assays, could we pull out the good actors, give them less treatment, and pull out the bad actors and give them more treatment. And that was a difficult decision to make. We were relying on a biological assay to dose reduce a group of patients who we knew had an optimal, an outcome of around 85%. We got very few dissenters from our parents, and we went ahead with that. So this is one little lad who came in. He weighed in with a white cell count of 90, not great. He's over the 50, as I was saying earlier on. He's 2, he's good, but he's a boy. Girls do better than boys, but that's life, isn't it? That's all the time. That's what happens. And he was entered onto this trial, UCAL 2003, and he was deemed to be intermediate risk. And James did all the things he should do. He was on Schedule B, as I say, negative MRD, this biological assay, and that's him walking down the steps there. Look at that. That's him there. Fantastic timing, James. Fantastic timing. Anyway, we had to, in the protocol, despite the fact that he had good chromosomes and he had a good MRD response, he qualified for the randomization of either 1 or 2 big blocks of chemotherapy. We call them delayed intensifications. He drew the big straw, 2 delayed intensifications, and after 3 years of treatment, he finished. And here he is in the summer of 2023, like all 18, 19-year-olds. 2 things that they need in their life is beer in front of them and a smartphone to text to the girlfriend, right? So that's James. Great. So trial starts to close. We know the answer in 2009. We can get rid of that second big block of chemotherapy if you have a favorable molecular response. And we also knew later on in 2011 that we could dose escalate for these patients who did not respond favorably, and we got more of those patients cured as well. This is just the data, just to show you that we've gone from an event-free survival now from 78 in the previous trial up to 88%, and the overall survival 92%. Best trial data in the world at that stage. And this just shows you we can dump the second delayed intensification. Both curves here are the same if you have a very good overall response molecularly. So this is the first randomized clinical trial to show stratification of treatment by this MRD response to improve outcome. And the treatment reduction, we are safe to say we could get rid of. More and more chemotherapy causes more and more toxicity in this population. So we're very keen to get rid of some of this chemotherapy, which we don't believe we need for all patients. And then in those patients who haven't got a favorable response, we escalated those patients. We got more of those patients cured going forward. 10 years later, I get a phone call. My mobile phone goes off, and it's James's mother on the phone. And she says, "Oh, I don't know how she had my mobile phone, but she had my mobile phone." And she said, "Surely this thing can't happen again." And I said, "What happened?" She says, "Kate, who you don't know, she's been off phone for about 2 weeks. It could be a flu. It could be one." I said, "Get a blood count." So Noreen brought her in, had a full blood count, and as you can see, she's under 10, she's a white cell count below 50, and she's good sided genetics at a high predict line. So this is lightning striking twice for 2 children in the same family. Fortunately, what James went through in that randomization, Kate didn't have to go through. She could omit her second delayed intensification if she proved negative on MRD at week 5, and she did. And hey presto, here she is in June 2019, free of leukemia and off treatment. And there's Kate now. Later on, she plays rugby. She's going to be the captain of the Irish women's rugby team. She doesn't know that yet, but I'm telling her she's a winner and she'll be able to do this. And this is the family after COVID. This is the brothers in arms earlier on. And then after COVID, this is Noreen, the 2 siblings here, and John, who's the silent partner in all of this experience, like most men are. So, but all that glitters is not gold. And this is Cara, and as I keep saying to a lot of the junior doctors, you always remember the patients you don't save. always remember them. Most of the patients you do save, they come in and they go out of your memory banks. But this is Cara. She comes in, she looks great. She's 8 years of age. Her white cell count is 4. It's good. She has a bit of coagulation disorder. She's bleeding a little bit. But when you look at her leukemia blasts, everything looks rosy. So she goes on Schedule A, like Kate. And then 4 days later, I was phoned that this was her cytogenetic result, and she has this translocation between chromosome 17 and chromosome 19. So this is essentially a death sentence. All of the children up to this time were have been on this particular trial, 2003, as you can see, incredibly rare. We've had 2 in the time I've been in Crumlin. All of these patients died from this particular type of leukemia. So what did we do? We told the parents that it's most likely we're not going to save your child's life. 2 days later, we were giving him an 85% chance of being cured. And here we went, escalated the chemotherapy, and we also started an experimental drug, the dasatinib at the time. There was animal data to show that there were some responses in animals. That is, she did well. She went into MRD remission, and then we went straight to transplant, a matched unrelated donor transplant using cyclophosphamide and total body irradiation. She engrafted, she had donor engraftment by day 22, and she was discharged home. And we thought we were on a winner, but then day 76, she started to bruise again, her coagulation was deranged, and when we did a bone marrow, her blasts were back, the same karyotype, the same cytogenetic abnormalities, and we had to counsel and get our palliative care physicians and Mairead O'Brien and the team really, because we were preparing this child to have a hemorrhagic death because this particular mutation was associated with hemorrhage. Fortunately, she didn't have that. She died peacefully at home with her parents and her siblings. So the current challenges then for the commonest cancer in under to 20-year-olds are that failures for current treatment is due to a mixture of under and over treatment. General more intensifications, it's not going to be the case here. We're at maxed out at toxicity levels for this, and we need to understand the biology better. We need to understand what that biology means in the background, positive or a very good molecular response or a minimal or a measurable residual disease. And we need to do more introduce more experimental drugs into this particular cohort of patients. These drugs are here. They've been licensed in the FDA in 2017 and in Europe in 2018. They're monoclonal antibodies. One sort of takes on the immune system, enhances the immune system. They're called BiTE antibodies, blinatumomab, inantumomab, and also this revolution in cellular therapies, chimeric antigen receptor immunotherapy. We're well equipped now in Crumlin. The leukemia lymphoma group is led by Andrea Malone. Don Barrett is there as well, and Angus O'Markey, who's been around with me since 2002 when I joined Crumlin with him. He retired earlier on this year, and we're in the process of replacing Angus. And on the stem cell transplant side, we've got 2 very bright young investigators, clinicians, Pam Evans and Valerie Broderick. So they're taking the gauntlet on now and moving this whole space into more cures, less toxicities, using this particular approach of immunotherapy on the backbone of other chemotherapy. We're about to start this particular trial. It goes across 15 European countries and also outside of Europe as well. And as you can see, it's a hieroglyphic. It's incorporating a lot of the immunotherapies. It's all incorporating a lot of genetic work as well. So it's really it's a difficult protocol to carry out, but it's going to be worth it. It's going to lift that curve, I would imagine, around 5% higher when we finish this trial, hopefully in about 3 years. The Europeans are well ahead of us in terms of opening this up. We've already had over 1,200 patients enrolled across 14 countries across Europe. So we're going to be bringing this in, not just for children and young adolescents, but also up to the age of 45. In Ireland, we're going to stop at 25. Now, I mentioned this earlier on, infant acute leukemia is an extremely rare disorder. But it's a different type of leukemia. It's incredibly aggressive, and it's got a different biology. These patients present with counts in the millions. They have brain involvement, they have, liver, spleen involvement. And as you can see here, they look completely different to what I've just been talking to you about, ALL. And the other, I won't have time to talk to you about today, AML, and it looks like it is a hybrid. And when you look at the markers on it, it does have myeloid and lymphoid markers. And then it has this nasty piece of work here, the MIL gene, which is rearranged in these leukemias. It's now called KMT2A. As I say, that unique gene expression profile. This is Keelan. Keelan came to us in Crumlin in June of 2009. She was 4 years of age. She had a count of over 1 million. And she had this MIL rearrangement, as I was just talking to you about. Big liver, big spleen, as you would expect. And the data that were just published from a trial that I was involved in as well, published in The Lancet in 2007, showed you could break this group of patients down into three. The worst group being the high-risk group here, where the survival rates were less than 20%. So if you had a MIL gene rearrangement, if you had a white cell count in excess of 300,000, and if you were less than 6 months, you were deemed to have really high risk infant ALL. And so I had to have a word with mum and dad and Gary, who are here this evening with Keelan, that, this was the stark reality. And unless we transplanted her, this is the outcome we were going to expect. We just launched a new Interfant 06 at that time, and Keelan fell into this particular area here of high risk, and she was going to have a stem cell transplant. And she did. She had a matched unrelated donor transplant using this particular conditioning in December of 2009. And when almost 3 weeks into this transplant, she developed the dreaded adenoviral viremia, and this has a mortality rate in excess of 70%. So we thought we'd already lost a couple of kids the previous 2 years from adenoviral infection. We started her on cidofovir. She started to engraft, and then she developed a total body rash, which we felt could be graft versus host disease, but didn't really look like it. Could it be adenoviral induced? Most likely. And then we got a very smart dermatologist over on the wards on an airline, and he looked at our bloods, which we did as well, but we didn't see what he was seeing. And he said this was a drug reaction to cidofovir. So we faintly stopped cidofovir. She started to get better. She had donor engraftment, discharge. Hey, presto, we thought we were on a winner. And then 3.5 years later, highly unusual. If you're going to relapse with this disease, you usually do it within 6 months after a transplant. Started chemotherapy again. She came back with leukemia with a vengeance. Here she is, a 3-year-old. She looks very happy there. And I wasn't very happy because I thought we were really up against a gum tree here. She had a second transplant, this time not from marrow, but from peripheral blood. And we had to condition her differently. We gave her cyclophosphamide with fractionated TBI and Campath, and then she had donor engraftment, and she was discharged then on day 21, a fairly rapid transplant in October 2013. And there's Keelan today. Keelan is here with Gary and Anne, and it's great to have them along here as well. Fantastic. Another big trial about to start, Interfant 21. And this is going to incorporate all those good things I was telling you about: immunotherapy, MRD assessments, genetics, etc., and the introduction of blinatumomab into this protocol. Again, we expect from the pilot that's been done and published, we're going to get more cure rates for these high risk acute leukemias in these children. Back to the failure syndromes, as these usually end up at some stage in the realms of bone marrow transplanters. And Melanie Cotter is here, Karina McMahon, and Beatrice, before she reinvented herself as a coagulationist, she used to look after these disorders as well. So some of them, I came across many of these at Great Ormond Street. Great Ormond Street was somewhat like a zoo where you go and see rare things. And Ian introduced me to a lot of these syndromes, like this one here, Cosman syndrome, infantile genetic agranulocytosis, where you don't have any neutrophils. And there's a genetic component. He described that in Stockholm or north of Stockholm. This is the most famous guy here, Guido Fanconi. He's not Italian, he's Swiss. discovers Fanconi anemia. We know a lot about the genomics of Fanconi anemia and how to treat these now. And this another one of my heroes, Louis Diamond. Louis Diamond, his name is on Black Van Diamond anemia in children, and also Schwachman Diamond. This is Harry Schwachman. He was a pediatric hematologist at Boston Children's, and he was a pediatric gastroenterologist at Boston Children's. So in December 2013, this guy was born, James. 27 weeks, born because of distress in utero, elective cesarean section, mum, Karen, intrauterine growth retardation. The first thing that was noticed when they drew bloods was that he had no neutrophils, Very unusual to be have no neutrophils. His hemoglobin was normal, everything else was normal. Came over to Crumlin, we performed the bone marrow, showed no diagnostic features. The cytogenetics were all normal, and he started to go off a little bit. He had multiple admissions to hospital for antibiotics, and we found that he was GCSF, this growth, this hormone that you can give to these children, and it promotes neutrophil development in the bone marrow, and they get less infections. But James was refractory. And then over the next 2 to 3 months, he started to developmentally delay, and he developed exocrine pancreatic insufficiency. So we felt diagnosis, that stuff I told you about when we were at Great Ormond Street, he and myself pulled together the Haematology of Schwachman. We felt this guy had Schwachman syndrome. And that syndrome was first put together in 1964, published in the Journal of Paediatrics by these two guys, as I mentioned, a pancreatic deficiency, bone marrow dysfunction, and genetically determined, as they described, 3 different children in one family having this condition. As you can see, it's rare, like most of these conditions, multi-system. And the one we were particularly interested in was the hematology. If you follow these patients long enough, and I remember leaving Great Ormond to go back to the Hammersmith and dig out files on patients in the Hammersmith who were already patients of Great Ormond Street 30 years before, these patients ultimately would develop what we call malignant myeloid transformation, AML or MDS, in around 1/3. We were first to publish this in the British Journal of Haematology. We got ahead of the sick kid people in Toronto on this, so that was a major coup. We had a couple of beers over that, Ian and myself at the Lamb. And the problem is when the only cure is stem cell transplantation, and it's got a huge high risk of transplant-related mortality. The genetics then, about 20 years ago, we discovered that over 90% of these patients have mutations in this highly conserved gene, the Schwachman-Bodian Diamond syndrome gene on chromosome 7. When we tested James for that chromosome or that genetic defect, he was negative, he was normal. And so, goes back to my mentor again, or my hero here, Louis Diamond. I found from experience that atypical cases, where we're dealing with an atypical Schwachman, turns out to be typical cases of something else. And the secret really is identifying to something else. Like most children in the last 20, 30 years with really rare genetic disorders, we've had to do what we call molecular odyssey testing. In other words, send samples, and James had this done, samples sent all over the world, or all over Europe at least initially. And then all of these started to come back as negative. We didn't know, what were we dealing with? And then more laterally then, myself initially sent stuff to Stephen Kingsmore at the Mercy Hospital in Nottingham in Kansas City in the USA, who were doing a lot of genomic screening, and laterally by Melanie Cotter to Christoph Klein in Munich. And I'll come back to that in a few moments. Can't be too academic about these really brittle children. What are we dealing with? What's the molecular pathology? We have to get on and treat the underlying cause. The underlying cause here was a stem cell problem, and we had to replace the stem cell compartment. So at the tender age of 1 in Crumlin, this is the old Crumlin, as you can see, a lovely bed there. See that, Alan? Alan Goldman and CMO from CHI's up the back there. These were the conditions we were working in back then. We'll come back to the conditions we're going to be working in a few minutes. He has an unrelated transplant as well. We don't do simply transplants anymore, as far as I can see, Pam Evans. But it's all unrelated, using this cocktail of drugs to condition them. And then James being James, James being James, after he engrafts, does beautifully, he develops a condition called post-transplant lymphoproliferative disease, big lymph nodes, big liver, big spleen, all driven by Epstein-Barr virus. So we had to give him rituximab. He responded beautifully, but then at 6 months post-graft, his neutrophils started to drop and drop. So they were experiencing graft failure. We tried to turn that around by getting the donor back, taking lymphocytes and giving him donor lymphocyte infusions, but that didn't happen. We had to go back and transplant him a second time, again from an unrelated donor, using a different conditioning with targeted busulfan. And here he is, Bob the Builder, or the poster boy, in a number of months after his second transplant. And there he is with his mum, Karen, with Simon Harris. I took him out of the picture, Simon Harris, and all of the other people that were involved in turning the sod at the for the New Children's Hospital in St. James's. He enriches the world. James enriches the world of Schwachman in terms of transplant outcomes. He's part of a family of 74 cases across Europe here, published in international peer review from the European group. But he's also enriched our understanding of the genomics of these conditions as well. I told you before, Schwachman up to then was really talking about being an autosomal recessive disorder, but this guy had one gene defect, a missense variant in the SRP54 gene, causing this severe phenotype. So he was autosomal dominant, and we eventually got that mutation, as you can see here, it was de novo, and we published that as well. Peter McCarthy is here, and Melanie Cotter in the British Journal of Haematology. So ain't no stopping him now, as you can see, from the boy in the bubble here, just a few years ago when he came to see me when I was going to do other things. There he is driving up the stairwell. And I'd like at this stage, I've just seen Deirdre McNamara and Colin Henry coming in from the HSC. We got Karen involved in this national strategy for accelerating genetic and genomic medicine in Ireland. She'd gone through a lot, and we wanted her voice to be present from a patient, parent advocacy on this, and she really contributed outstandingly well to this particular strategy. So let's just switch, coming near the end, to adolescents and young adulthood. And Brian mentioned this earlier on. I read this book back in '98, I think it was, and it blew me away, The History of Adolescent Medicine by Heather and Monroe Prescott. When I was at Great Ormond Street, one Wednesday in every three, I used to cross Gower Street to go to an adolescent cancer clinic. And I couldn't believe, this was back in 1988, 89. I couldn't believe how they were treating adolescents differently than what we were doing in the children's, or indeed back at the Royal Free, what we were doing in terms of the adults. And this is a beautiful quote from Heather. People have known since time immemorial, social science and increased the 20th century, adolescents are the people unto themselves, a distinct developmental category. And that beautifully summarizes, but nothing happened until the 1950s when they started to develop adolescent medicine centers in Boston and also at Stanford. And again, as I was saying, for cancer at UCL, they were the first, probably in the European Union, to start adolescent young adult cancer programs there. They are unto themselves, this cancer community. They have unique tumor types, increasing incidence, unique needs, fertility preservation, survivorship, transition, education, the whole social care around. And they don't want to be treated with Bob the Builder or the 92-year-old, the woman who listens to Live at 3 all those years ago. They want their own space. They want to do their own things at their own pace. So I started to agitate about this back in the early 2000s and whatever. I was fortunate enough to receive the 31st St. Luke's lecture, and the title is there, Improving Outcomes in Adolescent Cancer, Avoid Throwing the Baby Out of the Bathwater. What we learned from the stuff around ALL, we knew that when we applied those protocols to the adolescents with ALL, we could actually increase their survival rates by about 24-25%. There was a real pushback from our adult hematology community at that stage, but that was okay. We can live with that, and we did live with that. And now they've started eventually to move over. This is 2006. The second strategy was released in 2006. And the main outputs there were 8 designated cancer centres. Tick, great, fantastic. No mention of children. We're not good in this country at recognising children. And the NCCP was born, National Cancer Control Programme, and screening was all the way. So over the next number of years, I started to agitate even further. I started giving interviews on the TV, on the radio, etc., and went to the press as well. And as you can see, this is not the Sun, this is not the Mirror, this is broadsheet, sort of Sunday Times, Irish Times, and also other reputables again, and some friends who you probably know. This guy here is going on stage in about 5 hours in Las Vegas. Start to get behind this thrust. We need to change the needle here. We need to actually take on this responsibility and treat this community differently. So here we go. Got a phone call from Leo Varadkar, Trinity graduate. Benson came and worked for us in Crumlin. He was an SHO. I can tell you privately later on how he was. I won't do it in public. But anyway, he invited me on, and John Kennedy was the chair. This is John. He's up the back there. Michael Conroy. This guy's a centre forward. He wants to score goals. This guy's a centre back. He wants to stop you from scoring goals. And every time I put my hand up, Michael would say, "Oh, what is it? Is it going to cost us money?" And the answer was, yes, it's always going to cost us money. And here is Jerome Coffey, who was the director of the NCCP at the time. And guess who this is? You'll always notice a politician because they wear brown shoes for some reason. This was Simon. This was 2017 when we launched this particular thing. And the most important thing is that the National Children's Cancer Service at Crumlin was recognised as the 9th centre. But for the first time, the adolescent young adult cancer community was recognised as being separate. Recommendations. The new children's hospital. We've heard a lot about that recently. This is going to have an age and appropriate facility for adolescents and some young adults. This is the beautiful new children's hospital. We should be proud of this. This is a hospital. It's not an incinerator. And we must remember this. Whatever the cost is, the cost will be. We just need to get on and complete it. So it's 160,000 square meters of built. It's on 12.5 acres of real estate on the St. James's campus, which is a 44-acre campus. It's got 320 or 380 inpatient facilities, all ensuite, parents, etc., live in with their children. This is a game changer that this country and medicine in this country has never seen. From a cancer point of view, as I say, we're going to increase the patients coming in here up to the age of 20. We're increasing the capacity by about 50%, going from 19 beds at St. John's at the moment up to 20 beds. Age and socially appropriate infrastructure. This is what these particular patients cry out for. And also, they're going to have inpatient and outpatient places where they can do what teenagers do. You know it. You've been through adolescence. I know it. But I couldn't mention that to the Archbishop of Dublin when he was the chairman of the board of CHO. I said, what do you mean you need separate facilities for these people? And then I asked him the question, do you remember being a 16-year-old and having those thoughts that 16-year-olds have? And he said, we'll move on swiftly. So he got it straight away. And also, we're going to build a network across the country of adolescent young adult cancers system. Now, in 2019, I'm nearly finished. The NCCP appointed me the National Clinical Director. And the first thing I did with these two guys, my bosses here, Eileen Nolan and Fiona Bonus, was we pulled a clinical leads group. And a lot of you on that leads group are here tonight as well. And then we started off really well meeting in Parnell Street. And then COVID struck. We continued on. We eventually got a framework document out, which was published, which was signed off in 2021. And then the launch the following summer in Farmley with the Minister for Health. He's still the Minister for Health. And this is Richard O'Leary, the current director of the NCCP. And one of my favourite young doctors, Karen O'Neill, who was part of that clinical informative group, and she is a cancer survivor, so she was there telling us exactly what the needs are. and she is now working with us in St. John's Ward in Crumlin, and she's going to be a stellar superstar going forward. And then the network, we had to develop the network, and the only way you can do that is with manpower. You need a bridge to do this. And then, so we appointed these three really brilliant people, Sherelle Alkin, Peter McCarthy, and Neve, AYA Medical Oncology, AYA Haematology, Assistant Director of Nursing, with a real focus on adolescents. And we've been developing the implementation of this over the last number of years. St. James's, of the 8 centres, St. James's, Galway and Cork were selected to be the centres, and we've now put workforce into those centres as well. And we're going to see the fruits of this coming through very shortly. Back to the Children's Hospital. Have to keep talking about the Children's Hospital. Site location. Remember, it was refused in Eccles Street. You couldn't swing a cat in Eccles Street, but it went through that whole process. We brought it back. It was refused by Board and all that. Johnny Harahan has since gone, but he was part of that particular Dolphin group here. James Riley, a previous Minister for Health. And this is the reason why it was chosen. Co-location with the right partner should enhance synergies, opportunities for all, creating a dynamic powerhouse of research, innovation, and education. Today's research are tomorrow's cures. This is where you lay it down. And from a clinical and academic perspective, we identified St. James's Hospital as the existing Dublin academic teaching hospital that best meets the criteria to the adult partner to co-locate. So there it all is, for excellence in research, education, and infrastructure. In other words, create an academic health science ecosystem or system for children and adolescents. It's not just a building. I keep saying to people when they interview me on the radio, oh, it's a building, it's going to cost. It's not just a building, it's a philosophy. We're going to build an academic health sciences program. Paul McNally is here. He's the Director of Research and Innovation. And as we heard earlier on, I'm handing over the gauntlet of CAO to Susan, who takes it over next week. It's a partnership that results in the practical and philosophical integration of the university and the clinical partners. Here it's more complex because we've got 4 Dublin-based universities. Dealing with one university is a nightmare, but dealing with 4 of them and in tandem as well, it's even worse. Okay, but the primary goal is aspiration, develop excellence in interdisciplinary education research, promote team science, promote patient care, community service, more importantly, to educate healthcare professionals, leaders of the future, and keep them in this country, and not allow them to go down to Australia or whatever else they're going to at the moment. After about 20 months, I nearly became an alcoholic, trying to convince the 4 universities not to set up a memorandum of understanding, which is not worth the paper it's written on, but a memorandum of agreement, a legally binding agreement between the universities, the 4 universities, and CHI. And this is Irish here with Michael Keane from UCD, Veronica Lambert from DCU. Colin got a lot of accolade here. He didn't sit through those 20 months. He's just a blow-in. It was Michael Gill, who looks a lot older than Colin, I tell you, and he looked a lot younger when we started on this process, and Hannah McGee from RCSI. We've signed that off. We have boards in place, and it's going to be fantastic going forward. So I'm going to finish up now. Clinical research collaborations. Can't do this. This is pure team science. You have to get out there into the international world. These are colleagues and collaborations across Europe, North America, etc., our clinical trial activity, etc. And there's lots of you in the audience who have really helped me over the last 30 years or so. And here they are. I'm not going to read them out. You can look there for 2 picoseconds to see if your name is not. If your name is not, sorry, I just forgot. Okay. And these are the patients. These are, that's my sister phoning. Will you take that, Jude? These are the patients, parents, and support groups. As I was saying to you earlier on, there are children that we don't cure, will always remain in our memory. Sometimes I wake up thinking about these kids. Why did we not cure them? Fortunately, we cure over 85, 90% of children now and adolescents with cancer. I'd also like to thank the support groups as well. These are every weekend 1 and weekend 3 in Crumlin. We get usually the winners of the All Ireland football and hurling. That's the great King Henry there from the Tipperary team. I was fed up looking at him because they were winning it every year. I said, Henry, can we get somebody else in? And he said, well, Tipperary. And I said, no. And this is the Dublin team that went on and run as well. But also these supporters here, Brownstown, the Awareness here. Brownstown is just a fantastic support to these patients. The Irish, the Children's Cancer Ireland, Patricia McColgan is here. Evelyn, I see Evelyn up the back there with a new rinse, I think, Evelyn. A new rinse from Canteen. She has been absolutely fantastic over the last number of years. Amy is here from the Irish Cancer Society, but also I would like to thank the National Children's Research Centre. They've been absolutely brilliant in giving us funding to redevelop the infrastructure, but also to develop new programs of research. And Jonathan Bond is here tonight, Professor Jonathan Bond, Professor of Haematological Molecular Biology in UCD, and it was through Jacinta Kelly, Ruth Barrington, myself and others, and UCD, Michael Keane, that we got Jonathan's post. And his research group are really starting to push the needle in terms of, research insights. Cannot not finish without family. Is that right? That's what I was told. So here we go. This is Robert De Niro. This is my father, my mother, getting married at Berkeley Road. And this is me here in the corner here, losing my religion, yeah? You see me? And this is my mum and dad at one of my graduations from here. As I said, I met Jude over a spleen that belonged to Richie Dardis, who was a 19 or a 20-year-old chap from Clane, and he was a poet. He was a fantastically inspiring young man, but unfortunately he went into what we call glass crisis and eventually had his transplant but died soon after. Anyway, Jude and myself used to go to southern Italy, Calabria. This is where I proposed to her under some music. Steady in. I know you don't do romance here, but yeah. And then we brought the kids back later on. Fikra, Hannah, Ewan. Jude came back with huge skill sets in terms of haemophilia nursing. She revolutionized haemophilia nursing in this country, started up carrier testing clinics, both in children, and went from Harcourt Street to Tala and then to James's, and worked with Mary Day and James's as well. I'd like to make a special acknowledgement of my in-laws. They were more like my father and my mother. JJ and Doug both had passed away over the last 2.5 years. That's taken a huge toll on you and the rest of the family. It's been a great venture of rugby with the boys, as you can see here. The younger guy, Ewan, much better player, but never got past the quarterfinals of the Senior Cup for Belvedere. And the other guy I would like to thank, he's not in this photograph, is John Russell. John Russell looked after Fikra, this guy here, for a number of years. Initially did a tonsillotomy, and then eventually the penny dropped. He was having hemorrhagic problems, wasn't really thriving at school, etc. I said, John, could you just sort him out? Eventually took his retropharynx out, nearly lost him, had to go to ICU with Brendan O'Hare. But he started to thrive, made it onto the Senior Cup of Belvedere, and they went on to win the Senior Cup final in 2017 after beating John Reynolds there, Michaels in the semi-finals, and Barry White's up the back, Blackrock in the quarterfinals. So with that, I'd like to thank you for your attention and thank you for coming.